Hi, I am Raj Carmona, Assistant Professor of Medicine at McMaster University, and this is Brendan Flowers. Brendan is a clinical clerk here at McMaster. Over the next few minutes, we will demonstrate examination of the hand and wrist. There are a couple of things I want you to keep in mind though. Firstly, pain in the hand can arise from any of the structures within the hand. A good history will help guide your physical examination, and you should also allow the patient to localize the site of pain. Secondly, pain in the hand may actually be referred from any of the structures above, including the elbow, shoulder, and cervical spine. Depending on the clinical scenario, you may be required to do a physical examination of these areas and perform a neurological examination of the entire upper limb. For the purposes of this video, however, we will focus only on examination of the hand and wrist. Our demonstration will be structured into surface anatomy, inspection, palpation, range of movement, special test and functional assessment, and then we will finish off with a quick neurological screen. Let us look at some surface anatomy. We'll begin on the volar aspect of the hand. Remember that the wrist is composed of 2 rows of carpal bones with 4 bones in each row. The bony prominence in this area is the pisiform. Just distal and radial to that, you will find the hook of the hamate. Opposite to those structures, you'll find the scaphoid tubercle, and just distal, the crest of the trapezium. The flexor retinaculum traverses these structures and forms the roof of the carpal tunnel. This is also known as the transverse carpal ligament. The long flexor tendons, including the flexor digitorum superficialis and flexor digitorum profundus, fan out within the palm. These tendons are enveloped by the common flexor tendon sheath. You can also find here the flexor pollicis longus tendon and sheath. All of these tendons travel through the carpal tunnel together with the median nerve. Impingement of the median nerve can cause carpal tunnel syndrome. The extensor retinaculum traverses the dorsum of the wrist. The extensor tendons pass under this retinaculum in 6 extensor compartments. The most radial compartment is occupied by the abductor pollicis longus tendon and the extensor pollicis brevis tendon. Swelling and tenderness in this area is consistent with de Quervain's tenosynovitis. Across from these, you would find the extensor pollicis longus tendon, which is responsible for extending the thumb. Between these tendons is the anatomic snuff box. I will demonstrate this by having Brendan raise his thumb against resistance. Now, within this anatomic snuff box, there are several important structures. The proximal border is formed by the radial styloid. The floor is formed by the scaphoid bone. Just distal to that, you may be able to feel a bit of the trapezium, and then the first CMC joint. The extensor tendons are wrapped in tenosynovial sheets, which extend about 2.5 centimeters proximal and distal to the retinaculum. Swelling and tenderness here may indicate extensor tenosynovitis, and a well-defined superficial bulge may form with wrist extension. This is known as the tuck sign. I would now move on to the MCP joint. The main point that I want to make here is that the joint space is actually about 1 centimeter distal to the tip of the knuckle. This is important when palpating for effusions. The PIP and DIP joint space correspond to the flexor crease. Again, you should take note of this when palpating for effusions. As with any other examination, you should ensure adequate exposure. In the case of the hands, this should be at least above the level of the elbows. You can put the patient's hands on a pillow and compare both sides. Now, there are tons of potential findings on inspection of the hands, and these will be driven by the underlying disease process. It is beyond the scope of this video to describe all of these. In general, though, you should take note of any swelling or erythema, particularly around the joints. Also, take note of any wasting of the muscles, such as the interossei, the thenar eminence, and the hypothenar eminence. Wasting of the thenar eminence can occur in carpal tunnel syndrome. You should be familiar with the findings in common disorders. For example, in osteoarthritis, you may find squaring of the wrist, which is due to prominence of the first CMC joint. This is caused by osteophytes at that area. In osteoarthritis, you may also find bony enlargement of the PIP joints, known as Bouchard's nodes, and enlargement at the DIP joints, known as Heberdin's nodes. In rheumatoid arthritis, one may find swelling at the wrist, prominence of the ulnar head, radial deviation at the wrist, and ulnar deviation at the MCPs, sometimes with subluxation. Swelling at the MCPs and PIPs are fairly common in rheumatoid arthritis. Typically, though, the DIPs are spared in RA. In patients with long-standing rheumatoid arthritis, you may notice some classic deformities, such as Z deformity of the thumb, with flexion at the MCP and extension at the IP joint. You may also find Boutonier's deformity, with flexion of the PIP and extension of the DIP joint, and swan neck deformity, with extension of the PIP and flexion of the DIP joint. In psoriatic arthritis, you may find psoriasis of the skin, particularly on the extensor surfaces, involvement of any of the joints, including the DIPs. You may find swelling of an entire digit, which is known as a sausage digit or dactylitis. And you should also take note of any psoriatic nail changes, such as pitting and onycholysis. In vasculitis, one may see splinter hemorrhages and nail fold infarcts. Look on the palmar aspect for Dupuytren's contracture. This is caused by thickening and puckering of the palmar fascia. Begin with a general firm palpation while observing the patient for tenderness. For example, you can start across the wrist. Palpate the ulnar head. You can find the piano key sign here, which I would describe later. You can also palpate the ulnar styloid, the triquetrum, and in between these you can find the TFCC or triangular fibrocartilaginous complex. Tenderness in this area may indicate TFCC pathology such as a tear. Also palpate the APL or abductor pollicis longus and EPB or extensor pollicis brevis tendons. Tenderness and swelling in this area is consistent with the Quaverian stenosynovitis. You should also palpate within the anatomic snuff box for the radial styloid, the scaphoid, the triquetrum, and the first CMC joint. You may feel crepitus here by rotating the thumb. This indicates osteoarthritis in the first CMC. Also palpate over the scaphoid tubercle, the pisiform, and the hook of the hamate, as well as along the metacarpals for tenderness. Tenderness and swelling along the metacarpal may indicate prior injury such as a fracture. I would now demonstrate some specific techniques for palpating for joint effusions. You should also note any tenderness as you do this. For a wrist effusion, slide your thumb down the middle of the wrist until the tip of your thumb slides into the radiocarpal joint space. Press in to check for a tense or boggy sensation, which would suggest an effusion. Then slide the tip of your thumb over the radial margin. This should feel like skin sliding over bone. If the margin is difficult to feel, there may be a wrist effusion. The other common method is ballottement. Apply both thumbs over the radiocarpal joint space. Then, with one thumb firmly applied, press in with the other to see if you can push fluid across to displace the other thumb. Use enough pressure to blanch your nail bed. You can then switch thumbs. Be careful about ballotting normal soft tissues, though, and misinterpreting this as an effusion. We would now assess for an MCP effusion. The first thing to remember is that the joint line is actually about 1 centimeter distal to the tip of the knuckle. To palpate the MCPs, we use the 4-finger technique. You can use your middle or index fingers to support the underside of the joint being examined. And use the tips of your thumbs to feel the dorsal aspect. Make sure that the MCPs are sufficiently flexed. If the fingers are extended, the joint may actually feel full as though there is an effusion. With your thumbs in this position, there are a couple of techniques. First, you can apply firm pressure with both thumbs, enough to blanch your nail beds. Then roll your thumbs over and in and out of the joint. You should be able to feel the joint space pretty well. It should feel like skin sliding over bone. If the joint feels full or indistinct, this suggests an effusion or synovitis. The next technique is ballottement. With one thumb firmly applied, press in with the other to see if you can push fluid across to displace the other thumb. Again, use enough pressure to blanch your nail bed, and use your fingertips rather than the pad of your fingers. You can then switch thumbs. For PIP effusions, we also use a four-finger technique. Apply your thumb and index fingers to the dorsal and volar aspects of the joint. Apply firm pressure enough to blanch your nail bed. This will push any fluid to the side of the joint. Then feel with your fingertips for a boggy or spongy sensation, similar to squeezing a grape. This would suggest a joint effusion. Most importantly, make sure that your fingers are over the joint line. This corresponds to the flexor crease. If your fingers are a bit proximal, it would feel like an effusion as you palpate the soft tissues. You can actually do this to get an idea of what a joint effusion feels like. Again, use your fingertips rather than the pads of your fingers. You can also try to ballot fluid back and forth while feeling for shifting fluid, first with one hand and then with the other. We use the same four-finger technique for the DIPs and the first MCP joint. Don't forget to check for flexor tenosynovitis. This is a common cause of pain in the hand. Palpate for tenderness, swelling, thickening, or nodules along each of the flexor tendons. With your fingers over each tendon, passively flex and extend the finger, feeling for any tendon nodules, clicking, or catching. This can be found with a trigger finger. Range of movement should be done actively, then followed by passive assessment of a particular joint or finger if any abnormalities are detected. As a quick screen, have the patient make a fist with the thumbs out, then extend all the fingers. To assess the PIPs and DIPs, have the patient tuck the fingers in. Normal flexion at the DIPs is about 50 to 80 degrees, and at the PIPs, it's about 100 to 120 degrees. Next, assess movement at the MCPs. Normal extension is about 10 to 20 degrees, and flexion 90 to 100 degrees. To assess movement at the first MCP, stabilize the first metacarpal. Normal flexion is about 50 to 70 degrees, and extension 10 to 30 degrees. The first CMC joint is a highly mobile joint, which allows 40 to 50 degrees of flexion, extension, and 40 to 70 degrees of abduction, adduction, and also allows circumduction. Then, ask the patient to abduct and adduct the fingers. We will then assess movement at the wrist joints. Normal flexion is about 70 to 90 degrees, and extension is also about 70 to 90 degrees. You should also check radial deviation and ulnar deviation, as well as supination and pronation. The wrist joint also allows circumduction. We will now perform stability testing. You can gently try to sublux the wrist by stabilizing the forearm and moving the hand back and forth. A small amount of movement here is normal. Check for a piano key sign by pressing down on the ulnar head. If this is very mobile, it would depress and come back up like a piano key. This indicates disruption of the radio-ulnar ligament, as can be found in rheumatoid arthritis. You can also assess the MCP joints for dorsal and volar instability. This is similar to the anterior and posterior draw test of the knee. A small amount of movement is again normal. Next, assess the collateral ligaments at the MCPs. With the MCPs extended, there is normally a fair degree of movement. With the MCPs flexed, however, the collaterals become taut and there is little or no movement. Excessive movement in this position would indicate a torn or lax collateral ligament. You can also do collateral testing at the PIPs and DIPs. Carpal tunnel syndrome is caused by impingement of the median nerve as it travels through the carpal tunnel. The roof of this tunnel is formed by the flexor retinaculum. To perform the Tinel's test, percuss over the retinaculum. In a positive test, the patient will experience paresthesias in the radial 3.5 fingers. The next test for carpal tunnel syndrome is the Phelan's test. This is done by maintaining wrist flexion for 60 seconds. Paresthesias in the fingers constitute a positive test. We will then move on to the Finkelstein's test. This is a test for tenosynovitis of the abductor pollicis longus and extensor pollicis brevis tendons. This is also known as de Quervain's tenosynovitis, as we previously described. Get the patient to make a fist with the thumb tucked in and then passively bring the wrist into ulnar deviation. Pain along this area is a positive test. There are a number of things you can do for functional assessment. Importantly, assess the grip strength. Don't let my fingers go. You can assess the pincer grasp by having the patient pick up a coin or hold on to a sheet of paper. Another useful test is the key grip. Have the patient grasp and turn a key. A good test of dexterity is to have the patient do up a set of buttons, and you can also have the patient write a few words. We will now finish off with a quick neurological screen. For power assessment, assess the grip strength. This assesses power at the MCPs, PIPs, and DIPs. Assess the finger extensors across the MCPs. Don't let me push your fingers down. And the finger flexors across the MCPs. Don't let me push your fingers up. The dorsal and palmar interossei are intrinsic muscles of the hands and are supplied by the ulnar nerve. Test the dorsal interossei by having the patient abduct the fingers. Don't let me squeeze your fingers in. Test the palmar interossei by having the patient adduct the fingers. Don't let me spread your fingers out. Thumb abduction, flexion, and opposition are supplied by the median nerve. You can assess power here. Don't let me push your finger down. Don't let me break the ring. And you can do this at each of the fingers. Wrist flexion is also supplied by the median nerve. Stabilize the forearm and then try to push the hand up. Don't let me push your hand up. Wrist extension is supplied by the radial nerve. Don't let me push your hand down. As a quick sensory assessment, you can use a wisp of cotton, ask the patient to close their eyes, and say yes when they feel the cotton. A few things to remember. The median nerve supplies the radial 3.5 fingers, as well as the dorsal tips of these fingers. The ulnar nerve supplies the ulnar 1.5 fingers on the palmar aspect, as well as the dorsal aspect. And the radial nerve supplies the rest of the hand. You can test the median nerve via the volar aspect of the index finger and the ulnar nerve via the volar aspect of the little finger. The radial nerve can be tested just around the first web space. You can test the C6 dermatome at the tip of the thumb, the C7 dermatome at the tip of the middle finger, and the C8 dermatome at the tip of the little finger. We hope that this video was useful to you. Thank you for watching. I am Raj Carmona, Assistant Professor of Medicine at McMaster University, and this is Brendan Flowers. Thank you.